what is the need for classification? Yes, it should be able to identify any injury basically and should guide you in some treatment. So if you see this thing, like what do you mean by identification of injury? Like obviously the patient will come and say that I have an injury. So, but radiologically for communication with others and all those things, you should be able to do it. And the next thing is it should be clinically relevant. If you have a classification which is not clinically relevant, it doesn't matter at all, whatever it is and whatever it is going to say. What about reliability? Like am I able to classify it in the same way when I see it next time? And is my colleague going to do the classification the same way what I am seeing? There should not be a gross mismatch. Definitely there will be some mismatch will be there, but it should not be so gross. And how accurate it is, that is what I asked in the last question. No, what did you see intraoperatively? So he said there is a fibrosis. Which classification is going to say that inside there is a gap, or inside there is hematoma, or inside there was nothing there inside? Because that is what is going to make you to decide what is next going to do, the representation of reality. So is your classification is correlating with your intraoperative findings? So that is what we have to see in any classification. So this is just a history of classification. It started with 1929 with Bowler, where he started using his classification, then Watson Jones in 1939, Nichol in 1949, Holsworth in 1963, and as it increased, it came to Magrel AO, that is in 1994, and later Gaines classification for the burst fractures. So basically all these things dealt on anatomy and mechanism, trying to identify and understand what is the injury on seeing the radiology. So what was the need for a newer classification? Like all these classifications working before, but why a newer classification was needed? Actually, if you see till 2005, we were using all these classifications. After 2005, there was a marked jump. We started using many classifications. And why do you think these classifications were needed? All the previous classifications were personal experience. It was not based on any inter-observer or inter-observer reliability, and there was no consensus in providing the classification. One person decided based on my experience, I will do these classifications, then I will check it out and see. So then as our community increased, then we decided, okay, it can't be one person's decision, it has to be a consensus. So then came newer classifications. Main thing is reproducibility in classification, because if I make a classification, I can reproduce it very easily. But when I tell others to reproduce it, becomes very difficult. So unless you have a consensus-based classification, reproducing it becomes very difficult. So that's why the need for a newer classification came. So if you see this 2002 article where they were trying to classify thoracic and lumbar spine fractures with the problems of reproducibility. So they said that they used Dennis classification and AO classified by Magrel. That is 1994, and the other one was 1983 classification. And what they said is, like, although AO classification shows the mechanism and morphology, the reproducibility is very bad. Okay, that means intra-observer. Inter-observer might be good for these things. So even for experienced surgeon, it was a problematic one. And Dennis classification, they said that the variation is very high in Dennis classification. So AO classification, even though is better than Denny classification, but they said that is not adequate. Okay. So then assessment, this is another article which came like just by Vaccaro for the need of newer classification, that both Denny and AO, they said moderate reliability and reproducibility, and the tendency for a well-trained spine surgeon also, it was very difficult. Until 2005, no classification included neurological status. So all the classification were based on X-ray and radiology. And neurology is the one which actually make us to decide what to do for this case rather than the clinical picture. If a patient has a burst fracture, unstable burst fracture without neurological deficit, we might do with a fragment where we can put a screw into the fragment and fix it. But if the patient has a neurological deficit, then we will end up going and decompressing it. So this is what was missing with the previous classification. So they try to incorporate that. And they also found that MRI is needed, because many times we don't understand the neurological pattern. So MRI was needed, and 2005 they decided, okay, we will incorporate both these things and make a new classification. So there came the TLIS classification, TLISS, the Thoracolumbar Injury Severity Score classification, which came in 2005. So, and they also put a scoring system which guided in doing what to do, whether to do operative management or non-operative management. It was a good update from the previous classification, which was concentrating more on morphology alone. So then they try to compare the reliability of these three classifications, that is the Denny, AO and the TLIX, and they said, yes, TLIX seems to be acceptable, reliable and reproducible. So this is what they said in 2005. But was it a panacea? That means what is an universal remedy, that classification? So this article came in 2010 and they said should be an ideal spinal injury classification, because they were not happy with the previous classification, and came this horoscope matching classification. So this is exactly like horoscope matching classification. You need all these things. It is like getting an ideal spouse, which you are never going to achieve. So like these are things they had. You have to have an identification and terminology. You have to find out injury and treatment it should match. It should have all the characteristics, neurological factors, grading, prognostic factors. Everything should be there. That's what you have it in mind before getting married. This is what I need, all these things. So this is all the ideal classification. But where are we in the current situation? So with this, yes, they incorporated the AO classification in 2000. That was in 2010, and this was in 2013. So 2013, they put all these things, they tried to match up all those requirements and came up with this AO spine thoracolumbar injury classification system. Before this, I'm telling you, in 2005, when Vaccaro recommended MRI and made TLIX, in 2009, his own article said MRI does not tell you what is there intraoperatively, so and MRI is not mandatory. So after that, same Vaccaro, when he modified the classification on this one, he did not include MRI as a mandatory one. If you see TLIX, MRI was mandatory and was given points. In 2009, yes, people can make judgments, they can go error. But he analyzed his own study and he found MRI doesn't show whatever is there inside. Sometimes it shows more than what is needed. Sometimes it shows less than what is needed. So MRI, he said, is not a mandatory thing. And he came up with this classification, again going back to CT. So this is the current classification. So, and they put an injury score for this one also, which is going to guide you on the treatment. Yes. So, and this is the scoring system. So finally, it looked like an horoscope matching classification. It has all the combinations, everything is there. So did it answer all the question? Was it universally accepted? Has it replaced other classifications? So we have to see these two articles. So this is the article by Dr. Rajshekhar et al. And where he said, does the spine surgeon's experience, does it affect the fracture classification, assessment of stability and treatment plan in thoracolumbar injuries? Very simple questions. So he did all these things. So if you see this one, so if it is an A1 injury, everybody accepted. On seeing X-ray, 100% they said no treatment. CT they said no treatment. MRI they said no treatment. Only 5% variation was there. So the main problem was for A3 injuries. So if you show only X-rays, 64% said, I don't need an operation. If you show the CT to them, it became for 50% said that they need operation. If you showed the MRI, again they said they need the operation. So you see even with the same surgeons, the reliability started changing as you keep on increasing your evidence for it. So, and if you see the B2 also, like many of them accepted surgery, but what type of surgery, there was a problem. You can see it in this one. If you go through this, you will say not only between the surgeries, what surgery to do also is a problem. So to put it short, like the selection of a particular treatment plan was accepted only for A1 and C injuries. Okay. For A3, there was a problem between whether to do conservative or surgical, and for A4, the surgical approaches, they had a problem. So that means we all know we don't need any treatment for this one and we don't need any classification for this one. We all know that this needs surgery and we don't need any classification for it, but we want to know what type of surgery to be done. So that's what the classification should say. So the main thing is for the burst fractures and for some B2 injuries where we want to know what kind of treatment we have to do. So if you take the total number of cases in AO, they studied 1,445 cases. In that, burst fracture was 32% and type B injury was another 32%. So the ones which needed surgery were 67% and the controversy was 58% with the current classification. So even with the current classification, the controversy of doing a surgery is 58%. There is a controversy even with the current classification. So where are we? So this is how a classification is usually proposed. First you propose it, then you do pilot agreement studies, then you do multi-center studies, 2 minutes. And then you do clinical studies on this one. So where are we? Multi-center studies. Yes, AO spine fracture classification is superior. We are agreeing that. If you take clinical studies, this is a retrospective evaluation, recent one 2021 of 458 cases, and they found that TLIX is more conservative and the AO classification has more gray zone, and we have to give more license to decide what kind of surgical approach has to be done. So does it answer, does the current classifications or any classification answer all these things? Does it have a concise and descriptive terminology? Yes, maybe, may not be. Does it tell you the severity of injury? Yes, definitely it tells you. Does it guide to the choice of treatment? Definitely not, at least in my hands. And is it useful for further tools, studies, further? Yes, maybe. So this is my personal thing. I'm not quoting any experience literature on this one. So this is where I think we stand on the classification currently. Thank you.